I want to remind you that Sharsheret is a not-for-profit support and cancer organization and that does not provide any medical advice or perform any medical procedures. Our full medical disclaimer is in the chat. A quick program spotlight for all of you. If you're interested in giving back to Sharsheret, we're looking for new bakers to join our annual Pies for Prevention Thanksgiving Bake Sale, supporting the Stephanie Sussman and Ann Nadrich Memorial Jewel and Sharsheret's ovarian cancer program. You can become a baker and bake alongside over 40 sales across the country. Visit our website to learn more and sign up. And most importantly, if you're currently facing an ovarian cancer diagnosis, please remember that Sharsheret is here for you and your loved ones. Sharsheret provides emotional support, mental health counseling, and other programs designed to help navigate you through the cancer experience. All are completely free and confidential. Our contact information is in the chat box below. And if you are a member of our Embrace program, someone who's facing advanced ovarian cancer, we invite you to stay on the Zoom following the Q&A for a more intimate breakout session with Dr. Carlin. At Sharsheret, we know that ovarian cancer isn't just a diagnosis, it's a journey. Whether you're living with it or supporting someone who is, tonight's webinar is designed to give you the latest updates from one of the most esteemed ovarian cancer researchers in the country, Dr. Beth Carlin. Now, before we welcome Dr. Carlin to the screen, I'm pleased to welcome Lori to share her story. Lori, thank you so much for being here.
Sure. Thank you for having me. So I will keep this short. So my name is Lori Cohen. I hope I don't cry. I wasn't expecting that. I'm a very grateful 2-year survivor of stage 3 ovarian cancer. Looking back, I think the symptoms that led me to it are very simple, right? Like when we look at that beach acronym, I had some bladder discomfort, pelvic pain, all things I didn't really think were anything significant. But when I did finally get to my doctor, they found a mass. It was unclear what it was. Fast forward, imaging, surgeons, they scheduled me for surgery. And when I woke up, I woke up to a diagnosis of ovarian cancer. Very grateful for my surgeons, my doctor, and everyone, especially this organization. Once I kind of came out of the initial shock of it all and I started going into research mode, Sharsheret was one of the organizations that I came across immediately. And I remember doing a deep dive into old webinars and joining every Facebook group that you had. I think even ones that I shouldn't have been in. I was just looking for knowledge and others to help answer questions and just read other stories and hear other just stories of hope. Somebody from the Sharsheret organization, a genetic counselor, Rachel put me in touch with, because I had a lot of questions coming out of my genetic testing, because I have children, I have a daughter, I have a sister, I have nieces. So that was a great free resource. I was on a Zoom with a genetic counselor, answering all my questions, really helping fill in the gaps of what I didn't fully understand from my doctor. So that was really helpful. And yeah, I mean, it's been a journey, right? Surgery, chemo, I cold capped. I'm HRD positive, so I am on Lynparza, so a PARP inhibitor, which has been very, very grateful for that drug. So that's where I currently am. I'm about 15 months into what I believe will be a 2-year dose of Lynparza, and I'm thriving. I go for my scans, I meet with my doctor, but I'm living. I still am very research-based, so I'm constantly listening to new things, and I'm very grateful for Sharsheret for sharing webinars such as this with cutting-edge information, because you always just give me questions to go and ask to my doctors, and so I can keep up with, the latest and meet people and give them hope. So that's my story.
Thank you so much, Lori, for sharing your story. I'm really glad that you're doing well, and sharing your story makes a huge impact. So thank you for being so open with us tonight. We're now honored this evening to welcome Dr. Beth Carlin, who is a professor and vice chair in the Department of Obstetrics and Gynecology at the David Geffen School of Medicine at UCLA. She holds the Nancy Marks Endowed Chair in Women's Health Research and is the Director of Cancer Population Genetics at the UCLA Johnson Comprehensive Cancer Center. Her research focuses on early detection and precision prevention for ovarian and other gynecologic malignancies, as well as on identifying biomarkers to personalize treatments and improve patient outcomes. Recognized as an authority on inherited cancer risk, Dr. Carlin has contributed to the development of treatment guidelines and novel therapies for patients, and she's authored more than 500 peer-reviewed research publications. In addition to her many accolades, Dr. Carlin is a member of Sharsheret's medical advisory board. I've personally known her for over 9 years and have seen firsthand why Dr. Carlin is so beloved by her patients and her colleagues. And it's now my pleasure to introduce Dr. Carlin.
Laura, you're not alone. Now Jenna's going to make me cry too before I even start. So thank you, Jenna, for the wonderful introduction. Thank you to all of Sharsheret for all that you do. As Lori mentioned, building community that is supportive, that is knowledgeable, really does help survival. And there have been many studies actually looking at randomized groups and interventions of just this type of support. And women and men, but the women do live longer, live better, and I think have a much better quality of life. So thank you to all of you from Sharsheret. Big shout out to everyone who's on the Zoom this evening for you empowering yourself with knowledge, the opportunities to ask questions, and find out what else you can do to live longer and live better. It says you have a rich life, a life with purpose, and one you want to save and savor. So Jenna gave me the task of 35 to 40 minutes to sort of bring us up to speed. I've tried to include some of the hot topics. I can't go into everything in depth, obviously, but why is that not working? Let's see. There we go here. So this is the outline. We'll go over some of the current numbers and trends so you get a sense of that. Dry, but there's some exciting news there too. Really highlight that ovarian cancer is not one disease, and knowing about your own ovarian cancer, what subtype you have, has real clinical implications more and more with our targeted therapies. Go over some highlights of current standards of care, the use of heated intraperitoneal therapy, genetics and PARPs, really what's on the horizon, some clinical trials, the really new advent of antibody drug conjugates that we'll touch bases on, some comments about survivorship, and then self-injectomy and prevention. So that's sort of the outline, and I'll get going. Why are we here this evening, excuse me. Because of our families, because of our will to live, because of the long list of things we still want to get done. This is a very dear patient of mine for over a decade, with her husband and her daughter who was in graduate school and decided to start this run in her honor. And it went over 10 years. And her daughter Kelly now works with us in development and in our Sims-Mann Center at UCLA to help with survivorship. But she really started that legacy. Here's a clear cell ovarian cancer patient of mine at 5 years. And I told her we were going to celebrate that by making her cross a finish line that defined future successes in life. And here is a dear patient of mine whose mom I took care of. Her mom passed away from ovarian cancer. She had a BRCA1 gene, had risk-reducing surgery, and she brought her daughters in because she wanted them to have care too. So it's really about generations and knowledge and being active. And I think that's what I'm here tonight to try to give you some more information to do that. So where are we in 2025? About 20,000 new cases are estimated according to the American Cancer Society. About 12,700 deaths are predicted. For those of you who've looked at these statistics over years, and I hope you haven't, I just have, ovarian cancer is now down here at number 7. It used to be up at number 3 or 4. There really are positive trends for ovarian cancer despite the unfortunate increase in uterine cancers, colorectal cancers, and pancreas cancers that continue to go up, especially in women under 50. But our survival is improving. Overall now, there's almost 250,000 women in the US who are living with ovarian cancer. You see some age breakdown here, but again, more of a reason for you to be here, to find out how do you live longest, live best, and be able to make the most of every day. A piece of good news, when you look over these last 20 years or so, 15 years shown here, the long-term trends for both the new cases and deaths are decreasing for ovarian cancer. You know, I mentioned it in the last slide, but here you see from SEER, from our National Registry of Data, the blue are the new cases, the green are the deaths. Both are decreasing. In thinking about this a good deal, some of it is due to the greater use of birth control pills, which you know do decrease the risk of ovarian cancer. With cumulative use in our premenopausal years, if we're not saying use them after menopause, in the premenopausal years, they really do decrease the risk of ovarian cancer up to 50% by 10 years of use. The greater availability and knowledge about genetic testing in women who find out they carry an inherited predisposition to ovarian cancer, the fact that they act on it and have risk-reducing surgery, and again, the increased use of opportunistic scalpingectomy that I'll touch on in our prevention section. Mortality is better because we have better treatments, we have better chemotherapies, better trials, better targeted therapies. We've really begun to have really more individualized approaches beyond one size fits all, same treatment for every woman with ovarian cancer. And of course, we have better medical and surgical care to support women through their journey, whether it's growth factors so you don't get sepsis if your blood counts go low with chemotherapy, but really we have to keep going, obviously, but we have made some progress. This was the highlight from a National Academies of Medicine meeting we held almost a decade ago now, to really stop thinking of ovarian cancer as one disease. These subtypes of epithelial ovarian cancer, the most common kinds, are really very different. They have different genetic predispositions. They have different molecular biologies. They have different risk factors, and can have different treatments. And in fact, most of them don't begin on the ovary. The most common ovarian cancer, of course, is the high-grade serous ovarian cancer. Most likely begins, in most cases, in the fallopian tube. Those are the cells whose native epithelium, the native lining, is serous cancer, and it undergoes transformation, becoming malignant due to the constant insults, if you allow, of ovulation, where the rupture of the egg from the follicle has growth factors and enzymes that cause stress on those cells and cause them to become malignant. Low-grade serous cancer may have the same sort of last name of serous cancer, but they're very, very different. They're related in that they're both ovarian cancers, so to speak, but very different risk factors, biology, and treatments now, and FDA-approved treatments. Clear cell cancers and endometrioid cancers both likely begin from endometriosis. Again, different cancers, different treatments. And mucinous cancers, we're not quite certain whether they come from the gastrointestinal tract, like the appendix or colon, or elsewhere, but they too are very different. What does that say? And this, I'll go over, you don't need to have all the detail. Really, this is one of my slides that I use with some of my scientific lectures. But each of these major groups of low-grade cancers, high-grade serous or endometrial cancers, clear cell and mucinous, are really different. They have different genes, whether it's BRCA, CCNE1. I'm not trying to just give you word salad here, but each of these is specific targets with specific types of therapy. When you go to the low-grade cancers, you see different things. You see estrogen receptor, progesterone receptor, PI3 kinase. And again, the names are not as important as to understand that knowing the type of ovarian cancer you have can help you find a clinical trial, can help you understand what are the new FDA-approved treatments. There's new FDA-approved treatments for low-grade cancers, clear cell cancers, and these are all coming down the pike. So we need to stop thinking of ovarian cancer as just one size fits all, one disease. but these really are very specific. Similar, if you know, if you follow things at all with lung cancer, we know there are many different kinds of lung cancer that have specific targeted therapies on a pie chart being cut up into many different pieces. Each one can have improved survival if you get the right target, if you have that target and there is a treatment available. It is important. Research cures cancer. It's the ongoing partnership in research by both patients, clinicians, and investigators to have this bi-directional path from questions at the bedside to women being participants in trials or being willing to allow their tissues at surgery or elsewhere to be studied, that we can then make the discoveries, bring them back to the clinic, and iterate back and forth. And I've seen this from my own lab and from others, that this is really where we need to go. Okay, standard of care 2025. When a woman discovers that she likely has advanced ovarian cancer, there needs to be a tissue diagnosis. Either we'd like it to be more than just tapping the fluid that may accumulate from the ascites and cytology, but having a biopsy. And with consultation by a gynecologic oncologist, decide whether or not is it most appropriate based on her disease distribution and her other health indicators, comorbidities, other things she may have going on in her body, whether she should have surgery, or whether she should initially have her debulking with chemotherapy. So neoadjuvant chemotherapy is often used to kill the cancer cells prior to what we call an interval debulking surgery. And they have equivalent outcomes, whether you have your primary debulking surgery or interval debulking surgery after chemo, the overall survivals are the same. And that really has a caveat. That's after being evaluated by someone who, like a GYN oncologist, who understands both ways to treat this in terms of the surgical capabilities and not. So it's, your imaging, your CT scans or PET CT scans, what that shows to determine which tact is best. But the two both need to be evaluated. So the decision should be made by a gynecologic oncologist. If you have the neoadjuvant chemotherapy, sorry for the word salad, but there's just, otherwise letters get so small on here. So I'll try to repeat what they stand for. But if you have neoadjuvant chemotherapy and then interval debulking surgery, there's shorter hospital stay, fewer surgical complications, less bowel resections or colostomies. So in many cases, that is better for patients, but it depends on each woman and each woman's disease. The most important standard that we need to uphold is getting down to what we call R0, no visible residual disease. If your primary debulking surgery is not going to be able to get out everything, then you're better off having chemotherapy prior to surgery. Really, we know that the overall survival, how many years that woman's going to live, is correlated with getting down to no visible disease. The other thing that we're discussing more and more, and I'll show you some trials, is the use of heated intraperitoneal chemotherapy. This is at the interval debulking surgery, if they can get the tumor out, to use this methodology, and I'll show you a picture of it in a moment, where you heat the abdomen and heat the chemo to about 42 degrees. And that really seems to knock out any of those residual cells. You still need to finish your chemotherapy after surgery, but it seems to give you at least an extra year of survival, and I'll show you that in a moment. Also, standard of care is to make sure you get both germline testing done, so testing to see if you have an inherited predisposition, as well as testing your tumor, so which is HRD testing, as Lori said she had done, and that should be offered to everybody with ovarian cancer, independent of which type you have. The standard of care is still in the upfront setting to use carboplatin and paclitaxel for 6 cycles every 3rd week, and then you and your doctor can decide whether or not the use of bevacizumab, which is an anti-angiogenesis agent, should be used in your case. The way I think of it is the chemotherapies are like your lawnmower cutting off the top of a field of weeds. The bevacizumab attacks the blood vessels, the roots underneath, so that the blood vessels that would feed the ovarian cancer cells that remain would be also cut off. So again, there's pros and cons and risks that need to be individualized, but this is what would be in a textbook for standard of care today. As Lori mentioned, she did have HRD. So in her case, I'll show you beautiful survival curves, beautiful evidence of response. A PARP inhibitor, and PARP is a polyadenosine ribose polymerase inhibitor, which is why we call it PARP, does provide significant improvement in terms of both progression-free survival and also overall survival. And it really is a standard of care for women with advanced ovarian cancer, either carry BRCA germline mutation or of HRD. Okay. HIPEC. So basically what you do is you do your interval debulking surgery, you get all the tumor out, and then you take catheters, and the perfusionists, as we call them, are the same people who do cardiac bypass perfusion. So this is like not just a little thing. It really is a big thing. And they use the same type of machine that would be used if you're having cardiac bypass and everything's going through. And what you do is we use cisplatin. The chemotherapy is heated up to about 46 degrees, and then you put it into the abdomen for about 90 minutes. And the heated chemo opens up the cells, makes them more susceptible, and you sit there. Literally, I often have my residents in my fellows, and you basically have to just volley back and forth the abdomen and the fluid and keep it circulating. And you just do this back and forth for the 90 minutes and then take it out. It's a high dose, so you need to make sure there's protection for your kidneys and that you don't have nausea and all afterwards. But what you see here on my right, I think it's your right too, this was a phase 3 randomized controlled trial. So these patients had neoadjuvant chemotherapy, interval debulking surgery. Half the group got HIPEC and half did not. The red group, the red line of those that got the HIPEC and they lived longer, about a year longer overall, if they had the HIPEC. Now we still need no therapies, and I'm going to get into some of those targeted therapies, antibody drug conjugates, and where else. But this is a sign of something we can do 90 minutes extra. You know, I often sit down during that time and let the resident and fellow, help with the agitation of the abdomen. But I think it's definitely, I think any of us here, to buy another year of life for 90 minutes, it sounds like the best deal there ever is. So something else to consider if that might be right for you. Okay, germline genetic testing. This is for the inherited predisposition to ovarian cancer that runs in families. About 20% to about 1 in 5 ovarian cancer patients may have one of this. Most of them are due to BRCA1 and BRCA2, although there are other genes, as you see listed here, also associated with it. One point, Lori, and I'm using you, I hope it's okay, using your story as a way to thank you, sweetheart. I got the thumbs up from her. These genes are not on the X and Y chromosome. They're what we call autosomal genes. So they're the same type of genes that you can inherit eye color or other things with. So I know you mentioned the importance of being tested, and your female relatives are the ones you called out. Part of the, I won't call it a problem, but part of the issue is men are just as likely to carry and pass on one of these variants as are women. And the men who carry these genes also have risk of pancreas cancer or prostate cancer or male breast cancer, or in some cases colon cancers, or so I think that when we talk about this, whether it's around Rosh Hashanah, whether it's around Thanksgiving, when families gather, men don't follow through on their testing. They're really great. Even my physician colleagues, they'll say, oh yeah, I had my wife and my daughters tested. I said, well, what about you? They said, oh, I don't need to worry about that. Please encourage the men you love as well to consider if this would be appropriate for them. And I bring this up because despite the now 15 years since the national guidelines, National Comprehensive Cancer Network guidelines, have recommended genetic testing for every woman with ovarian cancer, we're barely at 35%. It's covered by insurance, it's covered by Medicare. It might allow you to have the access to PARP inhibitors, which not every patient has access to because they're not FDA indicated any longer. So please discuss this with your physician, even if you're on here, even if you're 80, even if you've been in remission for 5 years, If you've not had this done yet, please ask. One thing patients sometimes get confused about, and I'll go through it in a moment, even if you had genetic testing when you were, per se, pregnant and you had carrier screening, that's very different in a different type of genes. So please ask specifically about this. Not testing, as I said, missed opportunities for targeted therapies. Unfortunately, you can have second cancers. Lightning with one of these genes can strike twice. So you can have an ovarian cancer and then get a breast cancer or something else. And it would be good to know that you should have high risk prevention there too. And think of all those family members you could help save their lives. I have a dear patient who's a nurse practitioner, and every year I see she's out now more than 7 years with her ovarian cancer, but she brings me in pictures every year of the growing group of people in her family that she keeps getting tested, and it makes me smile. So as I said earlier, it can improve ovarian cancer survival. Over half of ovarian cancers are susceptible to PARP, either due to inherited mutations, that could be close to 15%. You can have a tumor mutation, like it sounds like Lori has with her HRD, or you can have what we call methylation, or other things that can alter the expression of these genes. And when you know that, you have access to PARP inhibitors. There can maybe immunotherapies depending on the alterations. And there's a growing list of these specific targeted treatments based on what gene you have altered in your tumor. So I think even if you've initially been diagnosed, when you have your surgery, whether it's upfront or whether it's an interval debulking surgery, it's important to get the somatic testing. I think one of the things I find with my patients as they live with ovarian cancer is often knowing what's next. You know, if it is to come back, do I have additional treatments? What else is out there? And every year, every 2 years you live with ovarian cancer, we're having more discoveries. This is really becoming more accelerated FDA approvals for ovarian cancer. So please have as much information as you can. Okay, you guys may have seen this in past years. I just think it's important to bring up again, and that's really how transformative PARP inhibitor maintenance therapy has been. It's a whole class of drugs. Lori mentioned she's on Lynparza, which is olaparib. There's niraparib and rucaparib that are also FDA approved for ovarian cancer. When these curves separate, it shows benefit. In the treatment arm, the blue one, every case, it's significantly separated. We have the most data for olaparib because it started the earliest. So Solo 1 is the trial. We now have 7-8 year data. But here, this was only at 7.5 years, and there was a 3.5 year benefit. These women had advanced ovarian cancer, all got to remission, and they were randomized to either placebo or olaparib. And those in the olaparib arm at 6.5 years had a 3.5 year survival improvement. So again, it's not a cure, but it's allowing you to get to that next stage, that next step, to go on to the next treatment that can get you another 3 years and another 3 years and another 3 years. And as an ovarian cancer community, I'm proud of what we've been able to bring forward into the oncology community, that the implications of PARP inhibitors, and they're not all the same PARP inhibitors, now have FDA approvals in breast cancer, pancreatic cancer, and prostate cancer, all stemming from studies that began in what we were able to demonstrate in ovarian cancer. So this is going to be the way forward, that we are going to be able to really not just throw a grenade in to kill every growing cell, but to really target specific mutations so that we can have less toxicity and have women live longer and better. Okay. I know I've thrown around terms tonight: germline, somatic, epigenetic, and just some quick things, because there's more stuff coming along the line. With someone asked about the Signatera test and things, and I'll get to that. So germline genetics is what you have from either a blood test or a buccal smear or saliva. It's a test, looking for a gene that you inherited. So it's been in you since before you were born. It's when the sperm and egg met. could come from your dad or your mom. It's in every cell of your body. It can be passed on to your kids by either men or women, as I said. A somatic change is due to, and we don't know exactly why. Part of it's due to ovulation, perhaps. Part of it may be due to other hormones, to antibiotics, to infections, but they are acquired over a lifetime. Somatic mutations increase as we get older. We're living longer. Ovarian cancer is not one that's associated with UV light, but we know that skin cancers increase because of the DNA damage from UV light. Things like smoking causes DNA damage in those tissues. So these are not inherited. They're acquired during our life. It's things we're trying to figure out what leads to this so we can prevent it. But they will define your cancer so that they'll be part of the targets. Now, as cancer cells grow, just like every other cell, they're growing really fast and their DNA repair is not very good because they're cancer cells. So the cells break off and they get into the bloodstream. The cells die, they burst. The DNA gets into the bloodstream. We now understand that we call it an analyte, something to study, to analyze. You can look at circulating tumor DNA, circulating tumor cells, which is CTCs, exosomes, little blebs that pop off. So sometimes we'll say, okay, maybe your tumors recurred and you didn't have a biopsy, we don't have tissue from before. We can do a liquid biopsy, which is to take a tube of blood to look for that tumor DNA and to do the same type of somatic analysis as we would have done with a tissue biopsy. And that too may say, has your tumor changed? Is there now a target that we can get to? There's also ways to look at unique fragments of DNA. And these are really bespoke tests to your tumors. You have your initial tumor. And when I talk about this, these are the pathology slides and blocks that are held by most departments, most hospitals, departments of pathology for a couple of decades. So they should be able to go back to your archival tissue and get one of those blocks. And they look at the DNA fragments that come out of your specific tissue. And then over time, that becomes your sort of bespoke, like we use a CA-125 traditionally, but a bespoke test to look for minimal residual disease. How early can we find that your tumor may be rearing its head again so that we can intervene perhaps a bit earlier? MRD testing, Signatera type testing, which was one of the questions folks asked about, and they're just one brand. So that's, for these circulating tumor DNA tests, can be used to follow things over time. I forgot, I'm sorry, I lost that, it'll come back to me, but it is something that you need to ask for. And it would be done after your tumor was diagnosed and can be used over time. We don't have yet for ovarian cancer specific national recommendations, although my patients have had no problem having them reimbursed by their insurers, but it's not yet in the national guidelines. Stay tuned, it should be coming. Okay. Antibody drug conjugates. If you guys haven't heard about it, this is, I think, an exciting advance in our treatment of all cancers. I'm optimistic ADCs may replace chemo even. This is basically a smart bomb. This is targeted chemo. Okay, so as you see over here, we have our cancer cell and we have all these receptors, antigens, things on the surface. So what an ADC is, it's an antibody that targets one of these. Many of you may have heard of Herceptin in the past. That was an antibody that just targeted these. But what we've done now with an antibody drug conjugate, we take our antibody, we have a little linker molecule that links the antibody to a drug. And this drug could be, again, it could inhibit DNA, could kill the cells in a number of different ways, similar to chemotherapy in general. And this has really, I think, revolutionized so much of the future for oncology care in that we don't just give you platinum or a taxane to kill all the rapidly growing cells that you lose your hair and things like that. These drugs are really much more targeted to those cells that have this receptor. And the beauty of them, one of the additional things is, so they bind on the cell. The complex, the antibody drug conjugate, is taken up by this endosome, this little, that piece where it's bound is pinched off into a little vesicle. It lyses so the toxins can kill the cancer cell that they're within. But when that cancer cell dies, that toxin is still there. So you get this sort of halo effect of, well, maybe not halo, but at least, it kills the other cells nearby that may not have had the receptor. So it really is a way to get even further effects of the drug with less toxicity. Okay, so these smart bombs to attack ovarian cancer, there's some that are FDA approved, some in clinical trials. Here's a list of some of the ones that are the most promising that are in trial. I'll go over 2 of them right now, but there's a lot more coming, and stay tuned. It's really very exciting. Again, they all have cancer cell, a little target, an antibody, a cleavable linker, and a drug that we call the payload. So the first one to talk about, and many of you may have heard about, is mirvetuximab, which is also known as Elahere. This is an FDA-approved ADC specifically for ovarian cancer that binds the folate receptor alpha that is on 90%, 80 to 90% of ovarian cancers. And it's not on the normal cells. So it has its FR alpha binding antibody. It has this cleavable linker. And here the payload, the toxin is what we call DM4. It's a tubulin targeting agent that doesn't let the cells reproduce. As I say, it's on 80 to 90% of ovarian cancers and limited on normal tissues. It's even on the low-grade tumors. I mean, this is really, really exciting. I won't bore you, but again, clinical trials is so important, and looking at the data critically is important because mirvetuximab has been around for a long time. Even got to a phase 3 trial called Forward a decade ago. It was negative, but it wasn't thrown out because they went back and they said, there's a signal here. Something's looking good, but we can't show in a randomized fashion that it's working. So they changed the cutoff. They changed the assay. They used ideal body weight and launched new trials. And it got accelerated FDA approval, now full FDA approval based on randomized controlled trials. And I'll show you that here. This is the Mirasol trial. Again, these were women who had platinum-resistant ovarian cancer. A place that's really hard since platinum is the most effective chemotherapy. Once you become resistant, you don't see improvements like this. And in this trial, again, it's not a cure, but we did see this significant improvement in progression-free survival in those women who got the mirvetuximab, the Elahere. And really, for someone with platinum-resistant disease, many of these women had on 5, 6, 7 prior treatments. It really was a game changer. And indeed, the FDA gave accelerated approval for anyone who had platinum-resistant epithelial ovarian fallopian tube or peritoneal cancer. There's ongoing trials now looking at platinum-sensitive patients, also showing excellent response, and really bringing it into the upfront setting. Okay, I'm talking too long. Let me go fast. Another one here, this is Destiny 2. This is an antibody drug conjugate that targets the HER2 antigen, similar to what was being done with breast cancer patients with Herceptin. This is now an antibody drug conjugate using the same antigen, the HER2, and this time linking it with something that's called a topoisomerase, a chemotherapy type drug. It's been looking at pan cancer, so cervical, endometrial, and ovarian cancer has been looked at, as well as others, and we really saw a great response for ovarian cancer. So another option, again, for someone right now who has platinum-resistant disease. And here's just a long list of antibody drug conjugates, and this is just a partial list and different targets that are coming forth. So something to think about, to discuss with your physician, to look at the NCI website to see whether or not this is right for you. Some examples of beyond these other cases, so specific genetic alterations, CCNE1 is common in about 20% of high-grade serous ovarian cancers, often difficult to target, RAS mutations, and these different subtypes that we now have chemotherapies and immunotherapies and targeted therapies that are really demonstrating improved outcomes. There's other novel immunotherapies ongoing, looking at vaccine approaches, T-cell therapies, and new types of antibodies that look at 2 different targets. The good news is patients are living longer with cancer, and our cancer death rate has significantly fallen these years. And they call it a silver tsunami because it is really, we're seeing more than 2/3 of these patients over 65 who continue to be able to live with ovarian cancer. And we need to think about ovarian cancer survivorship along a continuum, even pre-vivorship. Those women who find out they have a high risk and are BRCA1 or 2 or any of the genes and don't yet have a diagnosis, they need to be thought about too. Those individuals, women, from the time of diagnosis, you're a survivor. What does that mean? What can you do to improve your journey through chemotherapy, prevent or take care of your neuropathy, chemo brain symptoms, etc. And then ongoing, the anxiety for next recurrence, what does it mean? And this really needs to be incorporated into our standards of care. Issues that need to be addressed, of course, in menopause management, sexual concerns, fatigue, neuropathy, so many different things. Recognizing there's PTSD that goes with this journey that needs to be addressed. There may be accelerated aging with some of the cognitive issues, and really also the financial toxicities, the things that you need to put aside because you need to pay for treatments, and that needs to be taken into our survivorship plans as well. Many things we can be doing better by really understanding how they work. Stress reduction, physical activity. There's multiple studies now coming out about exercise. Really, there was a randomized trial recently in young colon cancer patients, how randomized to just being told to exercise versus given a coach for 2 years significantly improved survival. Diet, having your genetic testing. I'm an advocate. I've been talking about trying to launch a new subspecialty, just like we have now palliative care physicians, physical medicine, rehab physicians. I think we need to have a whole group of folks trained in survivorship to really take this on as not just the last 2 minutes and, go see the nurse practitioner. And I love my nurse practitioners. So please, that's nothing negative. They just often have more time. And we really need real clinical trials to understand what works, what doesn't work, so we can give guidance to patients. I'll just call out one of our physician's assistants, Rachel Frankenthal, has been very active in this, believing, she's a certified yoga instructor and provides a series of 8 to 10-week yoga classes for our patients, can be done on Zoom. And the surveys we have really show improved brain fog, fatigue, sleep, and these are ongoing for folks who can log in. They are free of charge as well. Okay. I'm getting there, Jen, I promise. An ounce of prevention's worth a pound of cure. The last section, I just have to, please allow me to say, almost better than curing cancer is never getting cancer at all. So I think we now understand that most ovarian cancers do begin in the fallopian tube. I say most, we think maybe, some of the low-grade serous and the mucinous may not, may begin elsewhere. But when we recognize this discovery, it really shifted the focus to risk reductive types of surgery versus, and I'm sorry to say versus, screening. We still are doing a number of screening studies, but so much has been invested. Hundreds of thousands of women have been.
Hi. Hi. I waved.
I can keep going. Yeah, I'm going to just keep talking.
Friday, so what I did was.
Okay. Basically, really, this is the most effective way, and it really will reduce the risk of ovarian cancer, both not just in the BRCA population, but this is really being looked at for women across the globe as a way to have an opportunistic self-injectomy to prevent ovarian cancer. So whether it's a GYN surgery, whether it's a tubal ligation, or desire for one at cesarean section or other surgeries, that when you remove the fallopian tubes, you significantly reduce the risk of ovarian cancer. So this was a large study done in Canada, women who had opportunistic self-injectomy versus those who had surgery but did not have their tubes removed. This was the predicted number of ovarian cancers one would have seen. But when you looked at the comparison from expected number of cases versus those that were observed, here for the high-grade serous cancers, 0 ovarian cancers versus those that were expected. When you looked at all epithelial cancers, those who were reduced, whereas the breast cancer and colon cancers were not changed. So this really does seem to be having an impact. And there's a number of campaigns now to try to get this more widely embraced, by both gynecologists and even talking to non-gynecologic surgeons to consider there. We've mentioned genetic testing and the need to do that. Remember that if you do carry one of the high-risk genes, to have your risk-reducing surgery by the specific ages. I think those women we see with these mutations who have their risk-reducing surgery 10 years later in their 50s or 60s do have a higher risk of having a cancer found at the time of diagnosis. And lastly, I mentioned earlier cascade testing, telling your family if you carry one of the high-risk genes about it and helping them also understand the risks and that they too can have prevention interventions for themselves. And this is just an example of this, what it means for your relatives. Most folks don't talk about this with their relatives. Families are complicated. It may sound easy. You haven't spoken to your sister. You don't know that cousin. But it's something that you really can have an impact on lowering the risks. We're actually working to put together an AI bot that can be your Siri that, hi, I recently found out. What does this mean? Can you help guide me? What do I do next? And give you sort of scripts and support of what you can tell your family members, how it's done, and give them information as well. So I think, what do we do now? And I'll stop for questions after this. Really implement efforts to broaden genetic testing, cascade testing for primary prevention. We've already pushed the survival curve significantly right. But when I was in training, women with ovarian cancer, the median survival was 18 months, and we're now close to 70 months. So we're doing better, but we need to have more cures. We need better treatments, especially since resistance happens to platinum, to PARPs, etc. We need more drug approvals, better insurance coverage, more funding, better ways to get patients paired up with funding, follow the national guidelines. They were there based on data, and really help train the next generation of scientists and clinicians to keep this coming. So September, it's Ovarian Cancer Awareness Month. Jenna, I hope your symposium can be pushed back to start on September 8th. And not till just the 26th, because we're kicking it off tonight. But talk, educate, advocate, live. And thank you for your attention. Thank you to Sharsheret for all that you do. Sorry if I went over a few minutes. I just wanted to try to get in as much information as I can for everyone who's been made the time to join us tonight. So thank you.
Thank you so much, Dr. Carlin. This was just so informative, and I've got your whole alphabet soup written out. So, so much information that is really critical for all of us here. Thank you. Just two things I want to mention. One is that Sharsheret's genetic counselors are available to help guide you in talking with cascade testing with your family. So please don't hesitate to utilize Sharsheret's resource in addition to the resources at your local medical center. Genetic counselors are a great tool to help you communicate with your family about reducing their risk. The other thing I want to mention is we are having a webinar on October 29th with Seth Cohen of City of Hope, Orange County, who is going to talk about managing the side effects of ovarian cancer treatment, in addition to a speaker who will be speaking about breast cancer side effect treatment. So please register for that webinar. I put the information about it in the chat if you're interested.
Jenna,
Okay.
Seth is the urologist. You know that. But he's talking about side effects of ovarian cancer.
Yes, and he's going to talk about urogynecologic side effects.
Okay.
Yes.
Yeah. Twin brother Josh is a GYN oncologist.
And Josh is, yes, the twin brothers who are both in the same field. We're very lucky to have them both. Lots of questions. I'm going to combine a few, and I'm going to stick to more general questions. So there was some chat early on when you talked about HIPEC, about if you can use it for reoccurrence as a tool. And then follow-up question about how people can find a provider that will offer it as a procedure, because it sounds like some providers won't.
Okay. So the best data we have from randomized phase 3 trials published in the New England Journal of Medicine, which again is a very controlled situation, was looking at doing it at interval debulking surgery. If you're in a situation where your tumor has recurred and it's amenable and appropriate to have a secondary surgery or a tertiary surgery, and they're able to get the tumor out, I think it's something to discuss with your physician. Typically in those situations, you are not platinum resistant, you're still platinum sensitive. That's one of usually the indications that you're doing the surgery. And HIPEC, we have done it for recurrences. I just wanted to provide the strongest evidence for why I think it is worthwhile. I started studying heated intraperitoneal chemo, believe it or not, it's been around, oh goodness, I don't want to tell you, but it was in the 70s. And we were looking at it then, and it really does have a lot of biologic background to it. So I think, yes, think about it. Most academic medical centers, larger health centers will have access to HIPEC. If they do cardiac bypass, they should have perfusionists. So that could be another thing. So I think you can ask around in almost any zip code and find someone.
Great. Can you speak to the prevention aspect? You spoke about fallopian tube removal. I know that so many people want to know, when is that magical screening going to be coming down the pipeline? What is the latest on prevention and detection?
Okay. The current evidence continues to grow, demonstrating opportunistic self-injectomy will prevent ovarian cancer, whether or not you have an inherited predisposition or not. The age that is right for you depends on, have you completed your childbearing? What is your future? If you have a BRCA gene, just for that group, do you intend to have pre-implantation genetic testing so that you don't carry a BRCA baby? If so, you're going to need assisted reproductive technology. And I've had medical students here at UCLA who know they have a BRCA gene, and we've done their, they say, I want to have only BRCA-free babies. And we've done their self-injectomy to reduce their risk at age 25. I've had other women who are 38. They have BRCA2. They really don't want to go through early menopause, and they just found out, and will take out their tubes then. If you have a BRCA gene, you still need, or any of the other genes, I'm just using that as a grab bag, you still need to have the oophorectomy done at the ages that are indicated in the guidelines, but it's a really good first step. Other things that can lead to prevention, I said birth control pills. There are some trials being done with vaccine therapies. I think those are still really early, but coming down the pipe. We don't want just cutting body parts out to be the only way to prevent cancer. We'd like to have some medical interventions that are easy, like a vaccine. Screening trials are ongoing. There's a new one being launched. Ovarian cancer, as I said, is decreasing. It's harder and harder to have a positive screening trial. I still believe I'm still helping to participate in a number of the screening trials, but it's still, I think, I've said too many times it's going to be 5 years away, and I don't know when at this point. So I'm really trying to focus on primary prevention right now.
For our folks who are facing clear cell adenocarcinoma, are ADCs available for them, or are there any maintenance drugs for it?
Sure. So yes and yes. Well, okay. Yes and yes. So maintenance therapy currently can and should be an aromatase inhibitor. Medicines that are often used for breast cancer, the anti-estrogens is what aromatase inhibitors are. There are good data, again, that going on an aromatase inhibitor in the maintenance phase can prolong survival. So that's something important to consider there. ADCs depend on your target. So I only went through the mirvetuximab and the, we call it DXT, the one that targets HER2. The name is also very, very long. Those can be on clear cell tumors. The other targeted therapy for clear cell cancers, while immunotherapies, drugs, checkpoint inhibitors like Keytruda typically are not very effective for ovarian cancer, many times with clear cell cancers, and there's more and more trials looking at combinations of checkpoint inhibitors for clear cell cancers. And I can think of more than a handful of women in my practice with advanced clear cell cancers who've had a complete remission and are still there by using combinations of checkpoint inhibitors like were used initially for melanoma. So subtype specific therapies are really important. You understanding what's in, what are the best targets in your tumor, and then what you and your doctor are most comfortable with. definitely
Great.
hope for everybody there.
Great, thank you. I know there's so many more questions in the chat that we're not gonna be able to get to tonight. Dr. Carlin, thank you so much for this informative webinar. Lori Cohen, thank you for sharing your story with us this evening. Tonight's webinar is sponsored by Merck, and we're grateful to our Sharsheret Summit sponsors, Merck, AstraZeneca, Novartis, Pfizer, Lilly, Daiichi Sankyo, City of Hope, Eisai, and GSK. Please remember that Sharsheret is here for you, and don't hesitate to contact us if you need any support. We are putting our evaluation link into the chat right now. Please take a second to evaluate our webinar so that we can get you more of what you need. And in a second, we are going to be staying on with our community of Embrace women, those who are facing advanced ovarian cancer. Dr. Carlin is going to offer a private Q&A for that population. We appreciate those who fit that description to stay, and we appreciate those who do not, to say goodbye. And we will be sending out our Zoom, our recording and transcript as soon as it's ready in the next couple of weeks. So thank you again for filling out the evaluation, and have a wonderful evening.